All right. Hey, Mustafa, can you hear me?
Yes, I can hear you.
Yeah. Hey, so looks like we got a small crowd today. So feel free to stick around, but I'm still going to record it so people can watch it later. So I'm just going to go ahead and proceed as if we had a packed house, but don't feel obligated to stick around. But I'll at least get it recorded so we can put it on YouTube for other people to watch. But I appreciate you stopping by at least. And
yeah, of course.
Up to you. Yeah. So,
okay, so thank you.
Yeah, we'll go ahead and get started. So if you guys haven't watched the first lecture, go back and do that first. I think that's going to be most helpful, kind of laying the groundwork for this session. So just wanted to go through a few practical problems, but first there are 3 critical slides that I want to cover. One, you need to be asking yourself, what questions must you ask when you're encountering an acid-base disturbance? So we covered this on our last session, but for our 4 primary disturbances, we've got a number of different questions that we need to consider. So for a metabolic acidosis, the first thing you got to do is figure out, is it gap or non-gap? The next question you've got to answer is there another metabolic disorder? And then lastly, you got to ask, is there an accompanying respiratory disorder? Okay, for the metabolic alkaloses, really just got to figure out, is it chloride responsive or chloride resistant? For our respiratory disorders, for both our acidosis and alkalosis, the two questions you've got to ask is it acute or chronic, and is there an accompanying metabolic disorder? Okay, so that's our first critical slide. Second critical slide is figuring out an approach. Okay, so again, we covered this in the last session, but step one, figure out is the patient acidemic or alkalemic. Step two, determine what the primary disturbance is, whether it's respiratory or metabolic. If it's respiratory, determine chronicity. If it's metabolic, determine if there's a gap. And then lastly, determine are there any other disorders present. And then our third critical slide are the formulas or equations or ratios that you've got to know. Okay, so you need to know how to calculate an anion gap. You've got to know about delta delta. You've got to know about Winner's formula, and you've got to know about this this cartoon here, which allows you to determine chronicity of respiratory disturbances and allows you to determine are there other disorders present in respiratory disturbances. So if you have all this stuff down or easy to access, and you know the questions to ask and you have an approach, then you should be able to figure out every type of acid-base disturbance there is. Okay, so let's get started. So for our first case, we have a 29-year-old male with a 14-year-old history of diabetes who was brought to the ER by his wife. He's comatose, but afebrile, and he's breathing rapidly and deeply. His blood pressure is 124/72, his pulse rate's 92, and he clearly becomes orthostatic upon standing. There's no other neurologic findings on exam, and his physical exam is otherwise normal. So here are our labs. Our sodium's 132, potassium of 4, chloride of 95, our bicarb's 4, our BUN's 22, and our creatinine's 1.4. Glucose is elevated at 520, and our ABG gives us a pH of 7.08, a PCO2 of 14, a PO2 of 100, and a bicarb of 5. So the first step for each problem, determine if the patient is acidemic or alkalemic. So in this case, the pH is low, it's below 7.35, so he's acidemic. Step two is determine if the primary disturbance is respiratory or metabolic. So this patient's acidotic and his bicarb is low, so that means it's got to be a metabolic acidosis. A primary respiratory acidosis cannot exist in the setting of a low PCO2 and a low pH. So if your pH is low, your bicarb is low, you know it's got to be a metabolic acidosis. So moving on to step 2B, if it's metabolic, the first thing you have to do is determine if there is an anion gap. So remember, our anion gap is our sodium minus our chloride minus the bicarb. So in this case, it's 132 minus 95 minus 4, which gives us a gap of 33. So normal is 12. So in this case, you have an anion gap metabolic acidosis. Okay, but you're not done. You've got to make sure that there aren't any other disorders present. So you've got to see, are there any other non-gap acidosis? And you need to see, is there any respiratory disorders? Okay, so how do we determine if there is another, or if there's another acidosis, specifically a non-gap acidosis? That's determined by delta delta. Okay. Again, we go into this pretty in depth in the first lecture, but let's work through it now. So we know that a normal gap is 12, but our gap is 33. So that tells you that the difference in your anion gap, or your delta anion gap, is 21. And just like we talked about last time, if your bicarb is currently 4, which you're given, and we know that we had to recently lose 21 bicarbs, and I'm not going to go into the details on that like we did the first time, but we know that we recently lost 21. So you have to ask yourself, what was the patient's bicarb before this gap acidosis started? There's 25. Okay, so we were trying to figure out what it was before we started. I've got this backwards actually. So your final answer is 4 because that's what we're currently sitting at. and we recently abolished 21. So it's actually x minus 21 is equal to 4. But your answer is 25. So this is the second part of delta delta. And since 25 is a normal bicarb, that means there's not another acidosis. Specifically, there's not a non-acidosis present because our delta delta gave us a normal bicarb. So our bicarb was at the level we expected it to be. The other part of step 3 is determining if there's an associated respiratory disorder, and we figured that out by using Winter's formula. So that's the formula here, and if we plug our numbers in, we get an expected CO2 of 14. Technically, we get a range between 12 and 16 because of this plus or minus, but 14. And our actual CO2 is indeed 14. So since our actual CO2 is equal to the expected CO2, that means there's no other associated respiratory disorder. Okay, so in summary, step 1, we determined the patient was acidemic. Step 2, based off a low pH and a low bicarb, we determined it's got to be a metabolic acidosis. And then when we started looking for, or since we know that it's metabolic, we had to see if there's a gap. We calculated an anion gap of 33, so we do have an anion gap acidosis. And then our last step is to see if there's other disorders. So through delta delta, we determined there's no other metabolic disorders. And through the Winter's formula, we determined there's no other respiratory disorders. Okay. Okay, let's go on to problem number 2. So we have a 46-year-old male with stupor and rapid respirations who's brought to the ER by his girlfriend. He has a previous psychiatric history of depression and multiple suicide attempts. His girlfriend is concerned that he may have taken some of his mother medications, but she's not really sure what it could be. His vitals and physical exam are unremarkable, and his urine drug screen is negative. So here are the labs for our patient, and we'll kind of we'll refer to these as we go through. I'll keep them on the page here. But again, step 1 is to determine if the patient is acidemic or alkalemic. We've got a high pH, it's greater than 7.45, so we know that the patient is alkalotic. Step 2 is determining the primary disturbance, whether it's respiratory or metabolic. And since the patient is alkalotic and his PCO2 is low, we know that the primary driver here is a respiratory alkalosis. You can't have a primary metabolic alkalosis if your bicarb is low and his bicarb is low. Okay, so we know he's alkalotic and we know the primary driver is respiratory. So our next step is to determine chronicity. As we talked about in the first session, for every 10 points that our PCO2 changes, the pH should change in the following manner. So if it's acute, it's 0.08. If it's chronic, it's 0.04. We know that a normal PCO2 is 40. Ours in this case is 12. Okay, so 40 minus 12 gives us 28. But we've got to divide it by 10 because it says for every 10 points of change in our PCO2. So we take 2.8 and, we take 28 and divide it by 10 to give us 2.8. So that means if this is an acute respiratory alkalosis, we would expect the change in pH to be 2.8 times 0.08, which is 0.224. If we subtract that from a normal pH, 7.4, sorry, if we add it to a normal pH, it gives us 7.62, okay, which is exactly what this is. So we know that based off of our expected change in pH, this should be an acute respiratory alkalosis. Now, let's just say we were assuming it was chronic. So here, it's still for every 10 change in CO2, but this is our multiplying factor. So we take 2.8 times 0.04, which is 0.11. If we add that to 7.4, it gives us 7.5, which is below what we actually are. So based off of the ratios, we know that this must be an acute respiratory alkalosis as the primary driver of this disturbance. Okay, step 3 is determining the presence of other disorders. For the acute respiratory alkalosis, which is what we're dealing with, for every dime change in PCO2, there should be a decrease of 2 pennies worth of bicarb. So what that means is, again, here's our dime change of PCO2, which we figured out on our last slide. Again, so it's 40 minus 12, which is 28, divided by 10. So there's our 2.8. Should decrease by 2 or bicarb should decrease by 2. So in essence, what we're doing here is 2.8 times 2, that gives us 5.6. So again, we're trying to figure out, is there another metabolic disorder going on here? So our expected bicarb is a normal bicarb 24 minus this new one that we calculated minus 5.6, which gives us 18.4. So our actual bicarb, which again is 12, is lower than expected, because if we just had a respiratory alkalosis, this ratio tells us that our bicarb should be 18, but it's not, it's 12. So if our actual bicarb is lower than what we're expecting, that means there also has to be an accompanying metabolic acidosis. Okay, but you're not done. You've got to kind of go down the pathway of your metabolic acidosis to know, is it a gap or non-gap acidosis? So you plug your numbers into anion gap equation, and you get a positive gap. So you have an accompanying gap metabolic acidosis. So let's summarize all this. So we've determined that the patient was alkalotic because his pH was above 7.45. Based off the fact that his PCO2 is low and that it's alkalotic, we know that the primary disturbance has to be a respiratory alkalosis. And then step 2A is to determine chronicity. Based off of the change in pH, we know that this has to be an acute respiratory alkalosis. And when we went looking for other disorders, we calculated our expected bicarb, which was higher than what we actually have. So that tells us there's also an accompanying acidosis, which was a gap acidosis. So the final diagnosis, this was salicylate toxicity, which can cause respiratory alkalosis and a metabolic gap acidosis. Okay. All right. Next problem here. So we got a 42-year-old chronic alcoholic brought to the ER. He's intoxicated. Here are all of our labs that are relevant, and I'll keep the labs on the screen. But first, is he acidemic or alkalemic? Based off of this low pH, you know he's got to have an acidosis. And then determining whether or not it's what the primary disturbance is by looking at your bicarb. And so if your bicarb is low and your pH is low, this has to be a metabolic acidosis. Next step, 2B, if metabolic, determine if there's a gap. So here's the math for that. Our gap is 22. So we know we have an anion gap metabolic acidosis. Now the question is, from what? We checked the lactate, it was negligible. His ketones are only weakly positive, which largely rules out alcoholic ketoacidosis and diabetic ketoacidosis or starvation ketosis. He's not uremic. His BUN isn't terribly high. So we've got this unexplained metabolic gap acidosis. So when you have an unexplained metabolic gap acidosis, you need to be considering an ingestion, specifically like a toxic alcohol ingestion or something like that. So this brings us to a quick sidestep into our approach, where this will work for most everything, but in the setting of an unexplained gap acidosis, that's when you have to check an osmolar gap, which will tell you if this is a toxic ingestion. Okay. In the setting of ingesting methanol or ethylene glycol, you're going to have an osmolar gap. So let's take a look at that. So we know from our last, our new report from last month, when you calculate osmolarity, it's 2 times your sodium plus your glucose divided by 18 plus your BUN divided by 2.8. Okay. So if we plug in our numbers, our calculated osmolarity is 280. Okay. but our actual osmolarity, which we've given because we've checked right here, okay? We checked the serum osmol on admission on this patient, is 300. 300 is a good bit greater than 280. So that means you have some type of unmeasured solute, which in this case is likely due to toxic alcohol ingestion. Now you can check methanol levels or salicylate levels or ethylene glycol levels. Salicylate does come back quick. Some of the other alcohols or some of the alcohols will take some time. And so you need to use this tool to figure out if there's an unmeasured solute when you have an unexplained gap acidosis. Okay, so we're not done though, right? We've got to see if there are any other disorders present. We got to figure out if there's another gap acidosis, and we got to figure out if there's a respiratory disorder. Okay, so figuring out if there's a non-gap acidosis, we determine that by delta-delta. We know that a normal gap is 12, and our gap, which we calculated, is 22. So the delta anion gap is 10. 22 minus 12 is 10. If our bicarb is currently 15, which is what we started with, and we know that we recently lost 10 bicarb due to the buffering here, what was the patient's bicarb before this gap acidosis started? It's 25, and we get that from 25 minus 15, again, I got my math backwards on here, but the answer, it should be 25 minus 10 is 15. The end result is that you've got an expected bicarb of 25, which means since that's normal, there's no other metabolic disorders ongoing right now. Okay, so we've determined there's no other non-gap acidoses present. Now we need to figure out if there's a respiratory disorder present. As we talked about, we figured that out by using Winter's formula. Okay, so we plug in our numbers to the Winter's formula, which will give us an expected bicarb, okay, which tells us that our expected, sorry, I said bicarb, our expected CO2 should be between 28 and 32 based off of Winter's. And our actual CO2 is 30, right in the middle. Okay, so based off the Winter's formula, we know there's not an accompanying respiratory disorder. Okay, so that tells us there's been appropriate compensation without any other underlying respiratory disorder at the same time. All right, so summarizing this, we know the patient's acidemic. We know that the primary disturbance has to be a metabolic acidosis because our pH is low and our bicarb is low. Our next step was to determine if there's a gap. There was a gap, and then we had to look for other disorders. So based off of delta-delta, we determined there's no other metabolic disorders. And based off the Winter's formula, we determined there's no other respiratory disorders. So our final diagnosis is a primary metabolic gap acidosis in the presence of an osmolar gap, which is likely due to a toxic alcohol ingestion. So this was an alcoholic who likely ingested ethylene glycol or methanol. Okay. All right. Problem 4. We've got a 39-year-old male who returns from a cruise vacation complaining of severe diarrhea. So here are his labs. Again, step 1 is we have to determine if the patient is acidemic or alkalemic. It's pretty straightforward. Our pH is low, so we know this is an acidosis. Step 2, determine if the primary disturbance is metabolic or respiratory. Again, our bicarb is low, our pH is low, so this has to be a metabolic acidosis. Okay. Step 2B, now that we know it's metabolic, our next step is to determine whether or not there is an anion gap. Okay, so we plug in our numbers, which gives us a gap of 12. So this is an acidosis, but a non-gap acidosis. Okay, but we're not done. We've got to see, are there any other disorders present? Now, for non-gap acidosis, there's no need to calculate a delta-delta because there's no gap to begin with. If you had a gap acidosis occurring in the same setting, then your overall equation would give you a gap. So in the situation where you have a non-gap acidosis, you know there cannot be an accompanying gap acidosis. Okay. But we've got to figure out if there's an associated respiratory disorder. Okay, so again, we do that with Winner's formula, which is given here, which tells us our expected CO2 should be 32, which is exactly what we start with. So what that means is we have appropriate respiratory compensation based off what our bicarb is, with no associated respiratory disorder. Okay. All right, so let's summarize case 4. We've got an acidemic patient, and the primary disturbance is a metabolic acidosis. We determined there was no gap, and since there's no gap, there's not an associated metabolic disorder. And based off of getting the exact carbon dioxide that we expected from our Winner's formula, we know that there is not another respiratory disorder. Okay, so this is a non-gap metabolic acidosis due to loss of bicarb in the stool from a diarrhea. Okay. All right. This last problem is kind of the classic hospitalist patients. All the other problems were kind of warm up to this one. Everybody needs to know how to do this problem because this is something that we encounter a good bit, and it kind of goes through everything. Okay, so we've got a 72-year-old male with a history of COPD who presents to the ER complaining of cough, dyspnea, fatigue, and fever. He's hypertensive, he's tachycardic, febrile, and hypoxic. You see our labs here, and you see the ABG as well. So again, I'm leaving the labs up here. Our first step is to determine if the patient's acidemic or alkalemic. Okay, that's the straightforward part. Our pH is low, so we know this has to be an acidosis. Okay. Our step 2 is to determine if the primary disturbance is respiratory or metabolic. So our pH is low, our bicarb is low, so this must be a metabolic acidosis that's serving as the primary driver of this disturbance. Okay. And now that we know it's a metabolic acidosis, our next step is to determine whether or not there's an anion gap. So we calculate our anion gap, which is 143, our sodium, minus 95, our chloride, minus 12, our bicarb, which gives us a gap of 36, pretty high. So we have this is a positive gap acidosis. Now in our case, this is due to the lactate. Okay, if you go back and watch the first session, you can see how lactic acid can create a gap. Okay, so we've gone down the tree to determine we've got a anion gap metabolic acidosis as the main disturbance here. Okay, but we're not finished. We've got to see if there are other disorders present. So the first question is there an associated non-gap acidosis? Okay, so we will work through our delta-delta. We know that a normal gap is 12, but our gap is 36, which we calculated, which means the delta anion gap is 24. So if our current bicarb is 12, which we're giving, and we know that we recently lost 24 from this value, what was the patient's bicarb before all of this started? It had to be 36. So, if you work your way back, if we start at 36 and we lose our 24, which we've determined, and we know we end at 12, okay, that gives us a delta-delta of 36. Okay, so that's a high bicarb. So since our bicarb is higher than what we'd expect in this situation, that means there's got to be another disorder going on, and or another metabolic disorder. So he's got an associated metabolic alkalosis. Okay. As we talked about in the first session, whenever you have an unexplained metabolic alkalosis, check a urine chloride. His is low. The patient's hypertensive in the setting of a low urine chloride. So that tells you this is a chloride responsive metabolic alkalosis. Okay. And again, that has to do with loss of chloride in the urine, retention of chloride in the kidneys when the RAS system is activated from the low blood pressure. Okay, so we determined there is an associated non-gap acidosis, but we've got to see, is there an associated respiratory disorder? So we do that by our Winner's formula. Okay. So if we plug our numbers in, we get an expected CO2 of 26. but our CO2 is 40, which would initially seem normal if you just glance at it. But what this tells us is that our actual CO2 is higher than what we would expect just based off the bicarb level. So because of that, that tells us we have an associated respiratory acidosis as well. Okay, so we've got multiple associated disorders. So let's kind of summarize that problem. Our first step was to determine acidemia or alkalemia. Our low pH tells us he's acidotic. Next step is to determine the primary disturbance. We know that he had a low pH and he's got a low bicarb, so the primary driver is a metabolic acidosis. Next step is to determine if there's a gap. We did that, we had a gap of 36. So our primary issue is an anion gap metabolic acidosis. But then we have to determine if there's other disorders present. So based off of the delta, our bicarb was higher than what we expected, which means we have an associated chloride responsive metabolic alkalosis. And then finally, based off of Winner's formula, it told us that our expected CO2 was lower than our actual CO2, which means there also has to be an associated respiratory acidosis. Okay, so this is kind of a classic case of a COPD patient coming in with sepsis. He's got an anion gap metabolic acidosis due to the lactic acidosis from sepsis. He also has a chloride responsive metabolic alkalosis due to hypotension and then activation of the RAS system. And he's also got this respiratory acidosis due to a COPD exacerbation. This is your kind of classic triple disorder that we, this is not terribly uncommon for us to encounter. Now, we don't always go through the patient as systematically as this. Often they get fluids regardless because they're septic, and so we don't really think about the metabolic alkalosis portion. And the fluids also resolves the metabolic acidosis. But a lot of your patients with obstructive lung disease that come in septic will have a triple disorder. Okay, that is the last slide that I had. As we talked about in the beginning, I've recorded this session for people to go back and watch the whole thing. But does anybody have any questions about anything that we went through?
I want to ask you if this is going to be on the final.
What's that?
Oh, hey, Tim.
Oh, hey, Matt.
Not sure how you're hearing me.
Yeah, I can hear you now. Yeah. Yeah. Any questions or thoughts from anybody?
Thank you.
Well, yeah, no, I appreciate you guys coming. We'll get this uploaded so everybody else can watch it, but thanks.
Thanks, Tim.